The comparison of role conflict among registered nurses and registered practical nurses working in acute care hospitals in Ontario, Canada. Abstract. The study aimed to describe and compare nurses' perceptions of role conflict by professional designation, registered nurse (RN) versus registered practical nurse (RPN), in three primary areas of practice: emergency department, medical unit, and surgical unit. This analysis used data N equal to 1,981 from a large cross-sectional survey of a random sample of RNs and RPNs working as staff nurses in acute care hospitals in Ontario, Canada. Role conflict was measured by the Role Conflict Scale. A total of 1,981 participants, RN equal to 1,427, RPN equal to 554, met this study's eligibility criteria and provided complete data. In general, RN and RPN mean total scale scores on role conflict hovered around the scale's midpoint 2.72 to 3.22. However, RNs reported a higher mean score than RPNs in the emergency department, 3.2 versus 2.81, medical unit, 2.95 versus 2.81, and surgical unit, 2.90 versus 2.72, where statistically significant differences were found. The effect sizes were negligible to medium in magnitude, with the largest differences noted between RNs and RPNs working in the emergency department. The results suggest the need to implement strategies that diminish role conflict for both RNs and RPNs. Background and purpose. Conditions of the work environment within healthcare organizations are thought to represent a significant contributing problem to occupational stress, O'Brien-Pallas, and others 2010. Nurses working in acute care hospitals often practice with competing organizational demands that conflict with their professional expectations. Herselinsky et al. 2014, Reckness et al. 2019, such as hospital system efficiency, initiatives that pull nurses away from care, Fox et al. 2016, or when nurses are required to perform the clerical duties of an absent unit clerk, Dalkey and Baumbusch 2015. Nurses are also subject to incompatible expectations from patients and their families, managers, administrators, and other healthcare providers. Liu et al. 2012, O'Brien-Pallas and others 2010, Tran et al. 2010, such as administrators' expectations that nurses quickly and efficiently discharge older patients who, in turn, need more time to be prepared, Fox et al. 2016. When nurses are unable to reconcile these differences, they experience role conflict. Role conflict occurs when an employee experiences competing, incompatible, and/or conflicting sets of expectations and demands in the workplace. Kahn and others, 1964, Katz and Kahn, 1978a, 1978 billions. Defined as the incongruity or incompatibility of expectations associated with a role. House and Rizzo, 1972. P. 474. Role conflict represents a significant occupational stressor. House and Rizzo, 1972. Role conflict has been associated with burnout. Pico, 2006. Spooner Lane and Patton, 2007. Tonkin Kutanes, 2009. An extended response to chronic occupational-related stressors. Stordur et al. 2001. Poor mental health and high turnover in nurses working in acute care hospitals. O'Brien-Pallas et al. 2010. Meta-analytic studies have found that role conflict is associated with nurses intent to leave their current workplaces. Ni et al. 2015. In Ontario, Canada, there are three categories of nurses: registered nurses RNs, registered practical nurses RPNs, and nurse practitioners, which require different levels of education and responsibility. This study focused on RNs and RPNs. Since 2005, Ontario RNs require a 4-year bachelor's degree in nursing for entry into practice. Stretton and others 2014, whereas RPNs require a 2-year diploma in practical nursing. RNS's education permits for greater foundational knowledge in clinical practice, decision-making, critical thinking, leadership, and resource management. College of Nurses of Ontario, 2018. Canadian acute care hospitals have begun hiring more RPNs to reduce nursing care costs. Bourne and others, 2013. Acute care hospitals in Ontario are the second largest, 22.4% employer of RPNs. College of Nurses of Ontario, 2017. Prior studies have found that different employees exposed to the same work environment can perceive and/or react to their work environment differently. Kang and Lim, 2016. We found few studies that describe and compare nurses' perceptions of role conflict by professional designation, RNs and RPNs. Research that advances understanding of the perceptions of role conflict that RNs and RPNs experience is needed to help administrators develop strategies to address the sources of conflict tailored to the needs of RNs and RPNs in different areas of practice and therefore sustain the acute care nursing workforce. This study addresses these gaps in knowledge. The objectives were to describe and compare nurses' perceptions of role conflict by professional designation, RN versus RPN, in three primary areas of practice: emergency department, medical unit, and surgical unit. Methods and procedures. The data for this study were obtained from a large cross-sectional survey that had a 55% response rate, Fox et al., 2016, and used the tailored design method by Dillman. The survey, which was approved by the Research Ethics Board at York University, included questions about nurses' work environments, roles and demographic and occupational characteristics. Nurses whose names were randomly selected from the College of Nurses C&O database were provided a mailed introductory letter stating the objectives of the study and informing them that a package would be sent containing the study cover letter, a description of the study and respondents' rights as research participants, and a questionnaire. 1 week after the package was mailed, a postcard was sent thanking nurses who had responded and reminding non-responding nurses about the survey. Up to 2 reminders and a replacement survey were sent to nurses who had not responded to the survey. The names and home addresses of potential participants were randomly selected from the C&O database using a random number generator in a statistical package and stratified to create a sampling frame for the project. A proportional stratified random sampling strategy was employed to select RN and RPN participants. The sampling frame was structured to reflect the distribution of eligible RNs 72% and RPNs 28% working in acute care hospitals, as tabulated by the C&O specifically for this study, Fox et al., 2017. All RNs and RPNs who met the following eligibility criteria were selected from the larger database to participate in the current study. 1 actively registered with the C&O, 2 Ontario was their clinical practice location, 3 employed in an acute care hospital, 4 position as a staff nurse providing direct patient care, and 5 primary area of practice was emergency department, medical unit, or surgical unit. In total, 1,981 nurses met this study's eligibility criteria. We applied a sample size calculation formula, Teherdoust 2017, to determine that this sample size was adequate to detect small to moderate differences in the level of role conflict as perceived RNs and RPNs employed in 3 primary areas of practice: emergency department, medical unit, and surgical unit. Role conflict was measured by the Role Conflict Scale, developed by House and Rizzo, 1972. The scale has 8 items that assess the extent to which an employee experiences competing or conflicting sets of expectations and demands in different situations at the workplace. Table 2. For example, 1 item states, "I receive incompatible conflicting requests from 2 or more people." A 5-point scale ranging from 1 strongly disagree to 5 strongly agree was used in the rating. A total scale score is computed as the sum of the item's scores and can range from 8 to 40, with higher scores indicating higher levels of perceived role conflict. The psychometric properties of the scale have been previously validated, and the scale has been used in numerous studies. Jackson and Schuler, 1985, Schuler, 1977. The scale demonstrated construct validity. Findings of confirmatory factor analysis supported a 1-factor structure goodness of fit index equal to 0.94, root mean square residual equal to 0.06, normed fix index equal to 0.89, Kellaway and Barling, 1990, with item loadings greater than 0.80, Gonzalez-Roma et al., 1998, Kahn et al., 2014. Illustrated internal consistency reliability. Cronbach's alpha coefficients ranged from 0.78 to 90. Samples of acute care nurses, Gonzalez-Roma and Lorette, 1998, Storter et al., 2001, and test-retest reliability are equal to 0.44. Schuler, 1977. In the current study sample, the scale demonstrated high internal consistency reliability with a Cronbach's alpha coefficient of 0.87 in the total sample and 0.87 and 0.86 in the RN and RPN subsample respectively. Primary area of practice, for example, medical unit, and professional designation, for example, RN or RPN, were measured using standard self-report questions, as were other demographic and occupational variables. These included age, gender, employment status, for example, full-time, highest level of education attained in nursing, shifts worked, for example, days, evenings, nights, weekends, and the name and location of nurse's primary hospital. We used information from the latter to derive a variable on the local health integrated network hospital region. As nurses worked multiple shifts, we created 4 dichotomous shifts worked variables: day, evening, night, and weekend. We reported the results that were statistically significant, and their effect sizes were included to aid us in interpreting the statistically significant results. Preliminary analyses included tests of the assumptions of the planned inferential statistics. Although we found no evidence in the literature that role conflict differs by nurses' demographic or occupational characteristics, preliminary analyses also included examining if RNs and RPNs differed by age, gender, hospital region, employment status, and shifts worked to identify potential confounding variables. Differences were examined using the chi-square test for categorical variables, for example, gender, and t-test for continuous variables, for example, age. Descriptive statistics were used to characterize the sample regarding its demographic and occupational characteristics, to describe nurses' perceptions of role conflict by professional designation in the 3 primary areas of practice. First research objective, we computed the mean and standard deviation of the role conflict scale as well as the score of each individual item separately for RNs and RPNs in each primary area of practice, emergency department, medical unit, and surgical unit, to compare nurses' perceptions of role conflict by professional designation in the 3 primary areas of practice. Second research objective, we plan to perform either an independent t-test or an analysis of covariance and COVA if the preliminary analyses indicated the need to control for nurses' age, gender, hospital region, employment status, and shifts worked. The 5-point Likert role conflict scale was considered a continuous variable similar to other researchers: Bacharach et al., 1990, House and Rizzo, 1972, Kellaway and Barling, 1990, Pico, 2006, Reknes et al., 2019, Tunk and Koutanis, 2009, and analyzed the total scale score of the role conflict scale, as well as each individual item separately for RNs and RPNs in each primary area of practice. Similar to other studies, Sidani et al., 2016, the latter was performed to better understand where RNs and RPNs in each area of practice differed in their perceptions of role conflict. The effect size, Cohen's d, was estimated to determine the magnitude of the differences in the mean scores for the role conflict scale and its individual items between the RN and the RPN groups. Effect sizes ranging from 0.2 to 0.3 indicated a small 0.3 to 0.6% medium and greater than 0.6 large between group differences. Ferguson, all analyses, other than effect sizes, were performed using SPSS-PC, version 24 IBM Corporation, 2016. Effect sizes were estimated using F-Size Torchiano, 2016 package developed in the R language, R Core Team, 2013. Results. Preliminary analysis of the total role conflict scale score and the item scores identified no violations of the statistical assumptions of the planned inferential tests. The assumption of homogeneity was met for the main effects of role conflict total scale score of the role conflict scale and each individual item. As such, use of the planned parametric statistics was supported. There were statistically significant differences between nurses' hospital region and equal to 1,946 DF equal to 13, Chetewu equal to 79.5 P less than 0.01. Most RNs worked in the Toronto Central and equal to 222 15.8%, whereas most RPNs worked in the Northeast and equal to 62 11.4%. There were also statistically significant differences between nurses' employment status and equal to 1,955. DF equal to 3, Chetu equal to 17.5, P less than 0.01, with more RNs and equal to 982 69.4% working full-time than RPNs and equal to 354 65.6%. Lastly, there were statistically significant differences between RNs and RPNs in terms of evening and equal to 790 DF equal to 1 Chetu equal to 11.6, P less than 0.6, and night shifts in equal to 1,353, DF equal to 1, Chetu equal to 16.8, P less than 0.8, among RNS, 14.7%, and equal to 535 worked evening shifts, and 27.7%, equal to 1,012 worked night shifts. Among RPNs, 17.9%, and equal to 255 worked evening shifts, and 23.9%, and equal to 341 worked night shifts. There were no statistically significant differences between RNs and RPNs for HT 1947 equal to 0.06, P equal to 0.95. Gender and equal to 1981 DF equal to 1, CHI2 equal to 0.01, P equal to 0.01. Day shift worked equal to 1, CHI2 equal to 0, DF equal to 0.37, or weekend shift worked and equal to 1,185 DF equal to 1, CHI2 equal to 0.004, P equal to 0.95. A total of 1,981 participants, RN equal to 1,427, RPN equal to 554, met this study's eligibility criteria and provided data representing 98.8% of the sample from the larger database. The completion rate for this current study was 99.4%. The mean ages of RNs and RPNs were comparable at 45.6 years SD 10.5 and 45.6 years SD 11.6, respectively. Table 1. A diploma was the highest level of education attained in nursing for the majority of RNs 68.5%, and RPNs 100%. A totals for each variable do not add to 1,981 because missing values were excluded from calculations. ED, Emergency Department, SU, Surgical Unit, MU, Medical Unit, less than or equal to 0.05, which E plus, than or equal to 0.01, plus 95% confidence interval. The analyses controlled for location of nurses' primary hospital, employment status, evening shift worked, night shift worked. An ANCOVA was used to compare level of overall role conflict, that is total scale score, as perceived by RNS and RPNs within each primary area of practice, emergency department, medical unit and surgical unit, controlling for hospital region, employment status and evening and night shifts worked. These variables showed significant differences by professional designation. RNS's total mean scores on the role conflict scale were higher than those of RPNs in the three primary areas of practice, Table 2. An ANCOVA was performed to compare the level of role conflict perceived by RNS and RPNs in each of the three primary areas of practice: emergency department, medical unit, and surgical unit. In this analysis, we also controlled for hospital region, employment status, and evening and night shifts worked. At the item level, Table 2, there were statistically significant differences of negligible to small magnitude between RNs and RPNs on medical units on 3 items of the role conflict scale. These items reflected having to bend the rules to carry out an assignment, receiving an assignment without adequate resources, and working on unnecessary things. The item scores were higher for RNs than RPNs, indicating that the average RN on medical units perceived a higher level of role conflict on these 3 items than the average RPN on medical units. For the surgical area of practice, there were statistically significant differences of negligible to small magnitude between RNs and RPNs on the following 3 items: receiving an assignment without the manpower to complete it, having to bend a rule or policy in order to carry out an assignment, and working on unnecessary things. The item scores were higher for RNS than RPNs, indicating that the average RN on surgical units perceived a higher level of role conflict on these 3 items than the average RPN on surgical units. For the emergency department, there were significant between-group differences of medium magnitude across 4 items: receiving an assignment without the manpower to complete it, receiving incompatible requests from 2 or more people, receiving an assignment without adequate resources and materials to execute it, and working on unnecessary things. The item scores were higher for RNS than RPNs, indicating that the average RN in emergency departments perceived a higher level of role conflict on these items than the average RPN in emergency departments. Discussion: to our knowledge, this is the first study to use a randomly selected sample to describe and compare acute care RNS's and RPNS's perceptions of role conflict. The sample mean age and gender are comparable to those of nurses in Ontario, but slightly higher than the national average of 47.6 for RNS and 44.6 for RPN's Canadian Institute for Health Information 2018. The study identified that RNS and RPNs in general reported medium levels of perceived role conflict, reflected by scores slightly below the scale midpoint, with the exception of RNS practicing in emergency departments whose scores were slightly above the scale midpoint. Our findings are similar to those included in an integrative review reporting that RNS and RPNs report experiencing role conflict, Kusiapia and others 2018. The few studies that included RPNs did not exclusively examine acute care RNS and RPNs perceptions, but rather included RNs and RPNs with unregulated healthcare providers, clerical workers, educators, and administrators in the same Ontario sample, McSee, Gillis, and Doran, 2007, and acute care hospitals with long-term and community care settings across Canada, Harris and Hall, 2012. Other studies administered items asking respondents to indicate the extent to which the role of the RPN was clear, not how RPNs themselves perceive their own roles, Lancashire et al., 2016. By surveying a random sample of acute care RNs and RPNs that was representative of the target population of Ontario staff nurses on demographic variables, College of Nurses of Ontario, 2017, Ontario Ministry of Health and Long-Term Care, 2014, this study overcomes the generalizability limitations of prior research, which tended to rely on non-probability samples and to not administer validated measures of role conflict. Our study identified that the mean scores on the role conflict scale and its individual items were generally higher for RNS than RPNs employed in medical and surgical primary areas of practice. Although differences were negligible to medium in magnitude, RNS practicing on medical and surgical units perceived higher levels of role conflict than RPNs practicing on medical and surgical units on the individual items, inquiring about the extent to which they work on unnecessary things and having to bend a rule or policy in order to carry out an assignment. RNS practicing on medical units additionally reported more role conflict than RPNs on the individual item, inquiring about receiving an assignment without adequate resources and materials to execute it, although the effect size was negligible. RNS on medical units would be responsible for more acutely ill patients than would be RPNs, as well as being responsible for providing leadership for the entire nursing team, which could include unregulated providers such as Care Aids, Dalkey, and Baumbusch, 2015. This means that RNS may be required to complete nursing tasks for RPN's patients, or even assume full responsibility of RPN's patients who become unstable, in addition to managing their own patient assignment, which includes the most acutely ill patients. Dalkey and Baumbusch's 2015 British Columbia study suggested that RNS perceived that RPNs did not always reciprocate them for the extra work they had to assume related to the RPN's unstable patient assignment. Thus, it is conceivable that RNS may have perceived that they had received an additional assignments without the human resources to complete it. The mean scores on the role conflict scale and its individual items were consistently higher for RNS than RPNs practicing in the emergency department, indicating that RNS reported more role conflict than RPNs. Statistically significant between-group differences were all small to medium in magnitude. Compared to RPNs practicing in emergency departments, RNS practicing in emergency departments reported more role conflict on the individual items, inquiring about the extent to which they receive an assignment without the manpower to complete it, receive incompatible requests from two or more people, receive an assignment without adequate resources and materials to execute it, and work on unnecessary things. Emergency departments are high-stress, fast-paced, unpredictable work environments, Creswick and others 2009. Patients admitted to the emergency department vary in levels of acuity. Most patients who visit the emergency department are not acutely ill or injured, do not require hospital care, and are not admitted to hospital Usher Pines and others 2013. Other patients are critically and seriously ill or injured and are admitted to hospital. RPNs work with stable patients and report a change in patient status and ask for direction from the RNS. It is likely that RNS would be assigned to care for more critically and seriously ill patients than RPN's College of Nurses of Ontario, 2018, which might account for the between-group differences in perceived levels of role conflict. Therefore, RNS in emergency departments may be working with more acutely ill or injured patients and have increased responsibilities that may necessitate working with multiple groups who may operate differently. Also, with a more acutely ill and injured patient care assignment, RNS may perceive that they do not have the adequate human and material resources to carry out their assignments. As well, RNs in all areas of practice are expected to be the leader of the nursing team. Leadership tasks include overseeing the evolving acuity of the unit, communicating unit workload to the team, and delegating tasks accordingly. The need for leadership skills has become more necessary due to the increasing shifting of work from more educated workers to less educated workers related to cost containment initiatives, World Health Organization 2010. Although further research is needed, it is possible that RNS in this study may not have been formally prepared to fully assume a leadership role, given that most had a diploma level of education. It is also possible that the expectations of the leadership role may place RNS at risk of experiencing higher levels of role conflict than RPNs. These leadership expectations and increased patient acuity can occur simultaneously, leading RNS to experience competing demands. The findings of this study have implications for administrators who can develop strategies to address the sources of conflict, tailored to the needs of RNS and RPNs in the different areas of practice. For example, managers may use the items of the role conflict scale to help foster communication surrounding roles that could help team members understand their own and one another's sources of role conflict. Managers could help team members understand one another's roles and the necessity of reciprocity in tasks tailored to the unit setting, thereby supporting nurses in managing role conflict. For example, if an RN is required to perform an acute intervention for an RPN's patient, the RPN could complete less acute tasks for the RNS patients. Managers could also foster communication about the unit workload and how all members of the healthcare team could support one another. For example, if the RN has many competing demands and was able to explain this to other team members, requests for assistance with less acute tasks would be understood. Other professionals who understand the nursing workflow and RNS competing demands could structure their work with patients in ways that supported both patients and RNS. Nurses could also learn to explain their competing demands in the moment and suggest a time when they would be available or other nursing team members who might be available to assist other professionals. The study has some limitations. We recognize that while the study has identified differences in role conflict between RNs and RPNs, the study does not explain why these differences exist. Future qualitative studies are needed to better understand why these differences exist between RNS and RPNs. The generalizability of the study findings outside of Ontario is limited. Future research is needed to validate the findings of this study in other jurisdictions. Conclusions. This study identified that RNS and RPNs experience a medium level of role conflict, with RNS experiencing higher levels of role conflict in all three areas of practice. The largest differences noted between RNS and RPNs were found in the emergency department, and the effect sizes were negligible to medium in magnitude. The findings from this study may provide information for administrators to address sources of role conflict. Consent for publication. We have received consent from all participants for publication. Declaration of conflicting interest. The authors declared no potential conflicts of interest with respect to the research, authorship, and/or publication of this article. Funding. The authors disclosed receipt of the following financial support for the research, authorship, and/or publication of this article. This work was supported by the Ontario Ministry of Health and Long-Term Care, Grant 06651, the Ontario Ministry of Research and Innovation, and York University. Dr. Soraya Sidani's contribution was supported by Canadian Institutes of Health Research. ORCID IDs. Baden Nauruzi, KIA-ORCID.org/0002-0002-5586-4282. MaryFox-ORCID.org/0003-0572-3892. Soraya Sidani ORCID.org/0000-0002-9115-2389. Sherry Dalkey, ORCID.org/0001-6599-3101. References. Biographies. Baden Nauruzi Kia is an assistant professor in the Department of Occupational Science and Occupational Therapy at the University of Toronto. Dr. Nauruzi Kia was a postdoctoral fellow at York University while working on this project. Mary T. Fox is an associate professor in the School of Nursing at York University. Her research focuses on gerontological nursing. She has held several grants as principal investigator from provincial and federal agencies to better understand nurses' needs in supporting older people during acute care hospitalization and the transition back to home. Soraya Sidani is a professor at Ryerson's Daphne Cockwell School of Nursing. Her areas of expertise are in quantitative research methods, intervention design and evaluation, and measurement. Sherry Dalkey is an associate professor in the Faculty of Nursing at the University of Alberta, Canada. Her program of research aims to understand how to improve nursing practice with older people. Deborah Trigono is an associate professor in the School of Nursing at Queen's University. Dr. Trigono's research focuses on patient safety, and she examines complex organizational issues such as patient safety culture, best practices for elder care, and improvement in teamwork and patient outcomes for high-risk obstetrical patients.